Afternoon, everybody. Thank you all so much for joining us today. This is our Southern CCR Continuum of Care webinar. This is focused on county sharing to support implementation. My name is Amy Jaffe. I am the county consultant for Los Angeles and Ventura with the Public Child Welfare Training Academy. My colleague Audrey Toussaint Shelby, who is also a county consultant for San Bernardino, is on the call. She's going to be helping me monitor the chat today, as well as Val Ryan, who is our manager of instructional design. She's going to be helping us with all things technical. This webinar is recorded. We have unmuted everybody because we were concerned that we weren't going to be able to identify the presenters, and we have lots of different presenters today. So we would just ask is that if you are not speaking, to please make sure to mute yourself either on your phone or on the computer if you are using the computer audio. Okay, so if what we are planning on doing is we're having all 7 counties, the southern counties, go ahead and each do a presentation. Each presentation will be about 10 minutes long. What we ask is folks go ahead, if they have questions, to go ahead and put it in the chat, which if you are on the computer, you can just kind of hover over the screen, and down below you'll see the little chat function. Please go ahead and type any questions you have into that chat box. We will do our best to answer any questions on this webinar. But given that we only have 90 minutes and we have quite a few presenters, we may be only be able to get to a few questions today, but we will ensure that we are able to answer all questions sort of post-webinar. This will be eventually loaded up on our PICTA website, so everybody can get a chance to see this again in the future. So with that being said, I think we are done with housekeeping. Is there any other housekeeping things that I need to go over, Val? All right, I think we're good. We're going to go ahead and start with our first county. Our first county is Orange County. So go ahead and so I'd like to ask the presenters to go ahead and introduce themselves. And you have go ahead and you have about 10 minutes to present your update on your implementation plan.
Great, thank you. Hi, this is Denise Churchill. I'm a Deputy Director with Orange County Social Services Agency, and I've been part of the CCR implementation since the beginning, and I'm happy to give our update today. I'm glad that you have the handout on the screen. Also listening in on our partners from behavioral health and also probation, and I think we have some of our juvenile partners, juvenile court partners online. So we continue to be most proud of our continued strong partnership with our county partners, and that would be child welfare, mental health, and probation, also education and the courts. And we feel like we continue to be innovative and have strong working relationships whenever we are implementing various initiatives and strategies. So that we rely upon that quite a bit as we continue to proceed in rolling out many of the CCR components. So that's what we're most proud of. We continue to have several subcommittees, and we have always had the Child and Family Team, CFTs. We added the Interagency Placement Committee and now the CANs to that. We might develop a separate CANs group for some of the very specific implementation, but right now we're really proud of the fact that we utilized our team decision-making, county staff, and have them as our CFT facilitators, because they're dedicated supervisors that have been doing facilitation for years, and they now, we call everything Child and Family Team meetings, and they're being very flexible and innovative. They're going out into the community, whether it's at a provider or a group home, at our shelter, caregiver homes, similar to wraparound, in offering Child and Family Team meetings to be flexible to families. We're also holding an initial Child and Family Team meeting at the time of removal if the child is not already in a placement. And then for those that are in a placement, and for all others, we are holding a Child and Family Team meeting within 14 days of the detention hearing. That way we can know that what the outcome is at the detention hearing, and if the child will remain in out-of-home care, and engage the partners and the members of the team to help for case planning, so that can go into the jurisdictional dispositional report for those investigators. So we're doing those well before the 60-day timeline for initial CFTs. We also implemented February 1st, so we don't really have a lot of data yet, but our manager for CFTs has developed a survey for the participants in the CFTs, so that we can learn more about if they were helpful and if they felt that we were engaged, and we'll be gathering some feedback on that. We continue to work closely with our providers, both the group homes transitioning to STRTP and our FFA providers. We've always had monthly forum meetings where those providers come together with us, and we've included mental health and probation and CCL, so that we can all be working towards CCR implementation. We also, for presumptive transfer, have come up with our forms and have some guidelines in place, and we feel that we're in a good place with that right now. RFA, we were an early implementing county, and we've had that in place since 2 years now, since February 2016. We're really pleased that much of the feedback that the counties and we gave were incorporated into the written directives 5.0 version. And though we have a backlog, we are working feverishly to get those backlogs approved, and really hopeful that we'll be able to maintain the workflow moving forward. But we've got a big lift ahead of us with the backload. Our shelter transition, we're a county shelter, and we got good feedback from the state that the plan that we submitted was strong. So we have a lot to build on, and we've had a lot of things in place over many years to really reduce the reliance on our shelter and reduce the numbers. And I'll get to some of the challenges, but you know, we are really working towards rallying our community and our staff around kids transitioning to the community within 10 days if they do go into the shelter. In terms of our challenges, excuse me, we continue to see that you know, policy often is behind, you know, what needs to take place now in terms of implementation. So we struggle a little bit with that. We do rally group together to really work out guidelines in place of formal policy being in place. But that's a challenge sometimes when, you know, we're asked to put something in place right away. So we can continue to work on that. Our biggest gap is really the children that won't qualify for STRTPs and need family-based care, intensive services, family-based care. And, you know, how are we going to work collaboratively with our FFA partners with technical assistance from the state so that we can really develop more resources for the kids that are stepping down from STRTPs, don't qualify for them, and or need intensive services in family-based homes. So we feel like that's our biggest gap, and we really don't want the shelter to be backing up because we don't have the resources in the community. We also need some clarification on and expectations around emergency placements with our group home and STRTP providers. We've had one provider that has really worked with us on an emergency basis, but to really shift and have that expectation be for all the STRTP providers to really accept that use on an emergency basis while we're getting the, you know, mental health evaluation and the IPC to really verify that that use meets the criteria within 30 days. I think we need some more assistance in that area. And our providers are really telling us they cannot meet, even with the provisional STRTP, the therapeutic requirements that are required for that without having the mental health contract in place. And it's a stepwise process. They have to have the provisional license in order for behavioral health to really enter into that formal contract with them so that they can do the Medi-Cal billing to hire the additional staff to have their therapeutic program. So we work in that area as well. We have a little bit of struggle around sharing of information at the child and family team meetings with our mental health partners there in the presence of the parents, and really clarifying what data sharing abilities we have. We're wondering how the CANS is going to interface with level of care and the CFTs. We have lots of questions about intensive services foster care and the support and services component that FFAs can do as a separate contract, about therapeutic foster care and that level of Medi-Cal billing that the caregivers are going to need to do for those notes. We have a lot of orders coming out of our dependency court and juvenile court around children having to be remain in county in their school of origin, all siblings together, and numerous hours of weekly visitation. And it's really hard for us to match all of those court orders to the few resources we have. And so we're really struggling in that area. And I think our next steps are really to reduce our RFA approval backlog. I talked about that. We want to call together in the next month or so a call to action forum that brings together our foster group home, faith partners, our recruitment people, all our agency partners to really rally around this gap that I talked about in terms of intensive services for children in home-based care, and really support us in our transition for the shelter to be a 10-day shelter. We are going to be reviewing all the kids that are currently out of county to make sure we've got all the notifications for presumptive transfer in place, and we're working on implementation of CAN. So I think I covered the majority of what I wanted to share, and I'm glad you have additional details in our handout if there are any questions.
Great. Thank you so much. I really appreciate that, Denise. I have to say, you know, it was pretty, you know, when you put in the very beginning, you know, what was some of the things that was the most important. I'm getting an echo. Are you getting this too, Val, or is this just me?
No, we're getting an echo. I think it might be on your end. If you have a phone line open and or your headset and your computer speakers, maybe just turn off your computer speakers.
Okay. That seems a little bit better.
Yeah, we weren't getting it before, but.
Okay. So, yes, so anyways, I thought that clearly what stood out was that a strong working relationship with your behavioral health and your probation partners. I mean, it was sort of clear that, you know, in terms of looking at kind of your successes, that a lot of those were really were wrapped up into that strong partnership, using that steering committee, setting, you know, the subcommittees, using kind of good, solid, adaptive leadership skills to sort of push down the work. So definitely saw some really great things that were happening there in Orange. Audrey, is there any questions in the chat?
No, not yet. We don't have any questions at this time.
Okay. So if there's any other questions, go ahead and type it into the chat. If not, I think we're going to move to Imperial.
My bad. I know I didn't get to really sit down and come up with, like, you guys talk about this, you guys talk about that.
That's okay. You got it, girl.
Yeah. I even said, hey, we
This is what I call the sparkles and diamonds part of the job.
I'm sorry, can we have folks mute their phone? We're hearing people speaking in the background. Thank you.
Okay, so let's go ahead and get Imperial started. If you can go ahead and give your presentation, your information is up on the screen.
Hi, good afternoon. This is Claudia De Leon with Imperial County. Can you hear me okay?
Yeah, I believe we can. Thank you, Claudia.
Okay, so I will be doing the majority of the speaking today, and that's because I was not able to rally up all my team members, and that's because whether we all had prior meetings scheduled for today or just being too many places at the same time. But I do have some of my partners from probation and child welfare here present with me, so they can chime in whenever they feel like it. And so I wanted to start off by saying that I know every time we have one of these, or we go out of county and we hear other counties speak about how much they've accomplished, I think Imperial County always feels a little bit behind the, you know, the time frames as far as like, wow, look at where they're at. But at the same time, I do want to mention that it does motivate us and invigorate us to come back to the team and say, okay, here we are. We're going to move forward in doing this. So if there's one thing we want to get out of today, is definitely listening to all the counties and then take away, either feel the same way with the barriers, because I do feel that our barriers seem very similar to other counties. So what I want to mention is that we do have, you'll see it's on my working well and challenges, is that we're a small county and it's the same key players at the table. you know, whether it's this implementation team, another initiative, another program, anything, we'll find that it's the same people, same managers, management at the table. So I really feel that that works very well for us. We many years ago, we already had something very similar with behavioral health. We had, I think, even we had co-locations going on where behavioral health was here with child welfare. So the communication part, the collaboration, and now probation is on board. We have our Office of Education on board. I feel that works very well in our favor. We do have a bi-weekly meeting where that's where we feel that at times we've struggled a little bit to get that momentum going, to finalize things that other counties already have finalized, perhaps an MOU or a protocol. But I do want to add that we did have a change in management from August 2017 on, and it definitely brought a different culture change to the table. And the need of urgency and necessity to move forward and fast. So I feel we've been progressing quicker with CCR goals as compared to maybe even the beginning of January of last year. So because we do work well with each other, and it's really easy to just pick up the phone, call our partner agencies at probation or behavioral health and say, this is what we have, this is the need, can you guys jump on board and do it today? And I have to give kudos to probation and behavioral health. They work very well with child welfare. So you can still hear me?
Yes, we sure can.
Oh, okay, just want to make sure. So we also have subcommittees where our implementation group has focused on the MOU, the CFT form, the protocol, although I will admit that we haven't finalized it on that. I would say we're maybe 95% finalized with MOUs and protocols. And then, of course, after that comes the training part of it for line staff to ensure that we still haven't identified staff to be doing CFTs. Not that we haven't informally done them, but to formally call them a CFT and have a facilitator, we're still in that process. So some challenges have been, as I previously mentioned, I feel, and I think the team feels the same when we talk about maybe feeling behind timeframes, that where we should be at already with implementation and rollout of certain aspects of it. But I do feel that we're making strides there. But a challenge is also with RFA. We, once again, in meeting with other counties and having those discussions, Imperial County is, I feel, trying to play catch up there with the backlog, with trying to fully implement or staff, I should say, the RFA unit. That took a while. So we're seeing now a lot more homes getting approved. They are relatives who have had children with them, emergency placement for several months. So we definitely need to go out and try to do a recruitment effort, because in also having an emergency shelter and also trying to work with our 10-day time frame, we don't have a lot of resources. We don't have a lot of RFA homes. We have some foster family agency homes, but not as many as we need. So we do have court orders for visitation, school of origin, and once again, that limited resources, it's very taxing on staff. We've been trying, back to staff and recruitment, we've been trying to fill positions here in child welfare, and I know we still have several vacancies that we haven't been able to fill. So some short or long-term plans is to continue to collaborate with our FFAs for recruitment and placement, develop the plan to ensure that staff is receiving ongoing training, And our biggest one right now, at least for child welfare, is the transition from to a 10-day shelter. I know today after this, we have a 4 o'clock meeting where we're going to be meeting and asking behavioral health to co-locate somebody with us there at the shelter. So I know it's not, it's kind of short and sweet. I wish there was a little bit more to report. Do you guys want to say anything? You know, but I do want to emphasize that the strong working relationships and the commitments that we have to the children that we all serve, that I think speaks. You know, a one sentence doesn't do justice for that, but I do want to, we have a really good working relationship.
Great, thank you, Claudia. Thank you, Imperial. You know, you guys you're small but mighty, and we really appreciate you participating today. Definitely know that being a small county certainly has some advantages, but also has some challenges as well. And we really appreciate sort of you sharing from your perspective, kind of what has been working and what your specific challenges are. And it does sound like you guys have done a lot of work, you know, in the last 6 or so months. So nice job there. Does anybody have any questions for Imperial?
And if I could just add one more thing, that when giving out kudos, I want to give kudos to all the other counties too. Whenever we reach out, or we have colleagues that we've met through meetings or trainings and such, and whenever we reach out and ask how they're doing something or this or that, they are more than willing to help us. So thank you.
This is Heidi from San Diego County from Polinsky Children's Center, and I had a question. Can you hear me?
Yes.
Yeah, Heidi.
Curious about co-locating a behavioral health staff at your shelter, and I'm curious what you hope to achieve by having a behavioral health person on site.
Hi Heidi, this is Pablo. You hear me? This is Pablo from the shelter. Heidi, we'd like to see if we can and see like that. Knowing each other, I guess, really helps, huh, Heidi?
Yeah.
We'd like to see if we can get somebody out there so that we can go through the process quicker to get our kids assessed, not only assessed, but connected to services, whether it be case management services or even being seen by psychiatrists or the whole KDA process. Just everything to be a little smoother and quicker for the kids, specifically towards the shelter kids.
Okay.
If we were to need it, yeah, just specifically for the shelter kids that are going to be there within that 10-day time frame. I don't think we're looking at it right now for all the population of our kids in general. It's more just for the shelter kids.
Okay. Okay. Thank you.
Okay. Thank you very much, Imperial. Val, if you can go ahead and get the presentations up for Ventura, that would be great. And then we will go ahead and start with Ventura County. Give it just a second there. Okay, Ventura County, are you ready?
Yes, we're ready. This is Carrie Garman from CFS. We're going to present as a group, so I'll let my group members introduce themselves as well.
Hi, everyone. It's Letty Morales with Human Services Agency in Ventura.
Diane Emmerich from Public Health.
David Swanson-Hollinger, Children and Family Services.
We have behavioral health on too, but I don't hear them yet. Probation was unable to make it today, unfortunately, due to other obligations. But we can go ahead and start.
Oh, yes. Can you hear behavioral health? We're here.
Okay, great. Okay, first slide. There we go. Okay, so at Ventura County, we have a very strong interagency partnership with child welfare, behavioral health, probation, and public health. We meet every other week to discuss all matters related to CCR, and when necessary, we work collaboratively on specific cases to discuss treatment options available across programs. David's going to talk a little bit about the formal evaluation framework and activities, the monitoring interagency implementation activities, developing shared outcome metrics, and the creation of interagency integrated aggregate data collection across domains.
You actually hit on a lot of it, but we're working with an outside consultant that actually works with us on KDA and is working with all 4 of our agencies to look at those elements that Carrie described, and actually we stole a lot of what we have on this presentation from a recent report we did for our executive level steering committee on how we're doing. A lot of it now is focused on process measures, but we're also looking at building some shared outcomes to really look at to see if we're really achieving the goals that we're wanting to achieve across CCR, really from preventing entry into the system overall to the far end of the system around permanency and reducing placement and home-based care. So a lot more to come, but we're excited about where this is going. And of course, at some point, we'll have to integrate it with whatever the state develops in this area.
Okay, child and family team meetings, our staff are really starting to buy into the practice, and they're recognizing that they're able to see a reduction in their workload as the support team steps up and takes responsibility for some of the action items. They've noted that these meetings are beneficial, so they're choosing to have them on a more frequent basis. And we're also looking at CFTs as a way to reduce the number of children coming into care. Okay, STRTP conversion. All but 2 of our group homes have submitted program statements to the county. We are doing a collaborative review process across the 3 placing agencies, child welfare, probation, and behavioral health. We review the program statements individually, and then we meet collectively as a group to go over them and discuss the various components of their statement and their plan of operations. And then we meet with the providers afterwards to go over the feedback, particularly in the mental health section, which seems to be the area that they have the most difficulty. We are continuing to see a decrease in group home STRTP usage across the board, so we're pleased with that. And let's see, David, resource, family, recruitment, retention, and approval.
Sorry, I have myself on mute. Yeah, we're also an early implementing county with RFA, so we're a couple years into this at this point. I think our processes are down pretty well. I think we're like many counties, and we're trying to reduce our time to approval, which I think is probably in the worries. We are slowly building up our number of foster homes. We've also had an increase, which we didn't expect in our system, in relative and net from caregivers, which is nice to see. Those percentages are dropped initially with RFA, but they're going up. Got a real innovative, active recruitment effort that's very much involving the community. We do contract out our family assessments, and we're kind of trying to figure out how to manage that process going forward, because it is growing, and it's not a small expense, so we're looking at that going forward. That's it, Carrie.
Okay. Behavioral health, would you like to talk about cats?
Sure. This is Maria. Can you hear me okay?
Yes.
Great. Perfect. So on February 1st, we started our CATS team, which is the Children's Accelerated Access to Treatment and Services. And all of the children who are entering the CFS system are receiving full mental health assessments by our assessment team, and they will all be offered short-term services. We are trying to we're trying to have our turnaround be 15 business days from the time the mental health referral comes through our door to the first face-to-face outpatient appointment. And I know we're really just, 26, 27 days in, but we've done a really great job in getting them either out to our community partners or to our clinical team to start working with the children that we've assessed. We're also in the process. Oh.
No, go ahead.
I was going to say, we're also in the process of finalizing our Ventura County CANs, and that will be incorporated into the assessment that our assessment team is conducting.
I should say on the CFS side, we're really, from the CFS side, we're very excited about CATS because it really is a recognition by behavioral health that just by the experience of abuse or neglect is enough for behavioral health to intervene and provide at least short-term services to our kids. So we're effectively have gotten rid of the old MIST process, and we're now just referring all children. So we're very excited about it. And the reduced time to services is fantastic.
We're also, thank you, David, we're evaluating this through EvalCore, as David mentioned earlier. We're, because this is funded through MHSA innovation dollars, we're trying to see if it's gonna work, and so far, so good.
Great.
All right, and then regards.
Oh, go ahead.
Oh,
sorry,
go
ahead.
Yeah, in regards to the psychotropic medication, you know, we're always collaborating very closely with child welfare probation and the public health nurse. We're really started this work group to try to ensure that, you know, we're all on the same page, that all the providers have the same information, and that psychotropic medication is being documented well, but you know, also that, you know, people do have access, people that need to have access to the information have access. So we're still, you know, working on that and just brainstorming some ideas.
I'd like to also jump in. This is Marie again. We've also brought on board as a member of the CATS team and LVN to help with the psychotropic medication communication.
Great, thank you. Are we done? Do you have anything else you want to add, David, on PsychMeds, or should we move on?
No, we only have a couple minutes left, Carrie, so we got to pick it up.
Okay. All right, you ready to talk about boot camp or family engagement boot camp with Kevin Campbell?
Really quick, we are trying to shift from all the process and policy side to really looking at the practice now that is going to support, you know, CCR and our overall efforts. So we just trained a vast majority of our staff and many of our partner staff in family engagement, which we think will really integrate nicely with the CFT process and our SOP rollout. So we're excited about how that will look with our work with families.
Okay.
That's it.
And then next slide, children and family team meetings, the coordination, scheduling, and tracking. We're still having some difficulty with ensuring that we're capturing all the CFTs that are happening, and scheduling around the family's availability is sometimes difficult. There's various levels of engagement with the safety networks and key partners, but when the team is strong, it gets a lot of work done. However, all teams aren't as engaged, and some families have limited support, which impacts the CFT. For STRTP conversion, we have uneven quality of program statements. Some program statements come in and they seem to be very thorough, very well written. They followed the outline set forth for them. And then other group home statements have lacked the necessary depth and are missing parts of the application and have other problems associated with them. There's a concern about the group home's ability to develop quality mental health treatment programs. Almost none of the group home statements have met the requirements for the initial review under Section 20. Our behavioral health department is really going above and beyond to offer assistance to small group home providers to get them what they need to submit their program statements to the state. And multiple program statements were submitted in a short period of time, which causes an increased workload for counties to manage the reviews. We've had all of them just seem to come in all at once, and it has caused a little bit of a backup. With all the demands with the CFTs, the LOC, the CANs, etc., we're seeing an increase in social worker workload, and unclear policies coming from the state makes the directives unclear and compounds the social workers' anxiety on those things. Okay, next slide. Okay, David, resource family recruitment, retention, and approval.
I think the only thing here to highlight is we are one of the few counties that's trying to pay a bridge fund for relatives that are emergency approved up to 75% of the full rate until they're approved. And as expected, that's turned out to be a challenge financially with a longer time to approval. And we're trying to figure out what to do with that level of care with regard to that. think I hit on the other items there.
Okay. And treatment continuum, the continued challenge of meeting treatment needs of children with the most significant needs. That continues to be an issue for us. All right, as to our TP conversion. Behavioral health, do you want to talk a little bit about this?
Yes, so, we do have quarterly meetings with our group homes, and we've had, presentations explaining, the shift in regards to, mental health services and all the expectations. And I think, our group homes are a little bit overwhelmed, so we'll continue to provide, the support. We plan to offer our group homes some trainings in the upcoming months in regards to, just various mental health, issues and policies, and just some guidance on the transition.
Okay, we talked a little bit about I know we have to hurry, the resource family recruitment, retention, and approval, so we'll skip that one. We have our rollout of TFC, LSC, CANS, and the revised time and care protocols. And we just recently held a Kaizen regarding psychotropic medications. Next slide. Who is that? Okay. Evaluation. David, do you want to talk about that? The outcome matrix?
I think we've covered all of this at this point.
Okay. All right. Then I guess we'll close. We're done.
So do we have any questions, folks? I think I saw some things in the chat, Audrey, for...
Yes, we have quite a few questions for Ventura. I'll highlight a couple, and then whatever we don't get to this afternoon, we will go ahead and post them on our website. So a couple of questions for Ventura. One question that came in is, can you share any quantitative outcomes due to your CFT use?
At this point, we're just trying to figure out how to track them better. We've got a report that we're developing to at least get a sense if we're hitting timelines. So we can share what we got, but we're just pulling data, from CWS at this point and trying to build the quantitative measures for it.
Okay, great. Thank you. A couple of questions came in around your evaluation measures. The question is, Ventura, would you be willing to share your evaluation measures with other counties?
Sure. We've got a couple high-level documents we can send through. I can pass on to Amy to pass to counties.
Perfect. And we can
get nice summary documents. They'll give a sense of what we're doing. Sure. I'll pass this to Amy.
Great. Thank you, David. We will post the other questions because there's about 7 different ones.
Great. Thank you so much, Santa Barbara.
Good afternoon. This is Noelle Lossing with Santa Barbara County Child Welfare, and we have 3 presenters today. We have Giselle Mendoza from Behavioral Wellness, Deborah Hartman with Child Welfare, and Julie Wilson with Probation. And Giselle is going to start us off on slide 2.
Thanks, Noelle. So I'm going to start off by speaking about our current strengths and areas for growth related to collaboration and placement efforts. So what's currently working well is that collaborative meetings are currently being held with CWS, Probation, and Behavioral Wellness, and we're doing pretty good on sticking to having these on a monthly basis. So that's been very helpful, just all coming together in one room. We all know how difficult that could be at times. So it's been working out. We have level of care assessments and trainings in place. We've increased electronic tracking of CFTs and services. Behavioral Wellness currently participates in all the AB 1299 conference calls. That includes the Inter-County Work Group, the State and County Implementation Team meeting. We don't have a process right now to relay some of the relevant information on those calls to CWS, so that's something that we want to continue to work on. Our quality assurance team is working on creating and updating policies and procedures. And again, that's something that we would like to really include our partnering agency, specifically CWS and Probation on, because a lot of those policies and procedures apply to the same youth that we're all working with and serving. I have to say it's been very helpful to receive the list of the AB 1299 contacts throughout the state. That seems to have been a key component to increase access to services in a timely manner, and it seems like something that was so simple, and we got it, and it seems to be working out really nicely. I agree with what somebody else said, that just everybody has been so collaborative, just statewide. So it's very helpful to be able to pick up the phone and call someone in another county. And it's even that process is a learning process because we're all in different phases of rolling out the different regulations and legislation. The other thing is all our staff at the children's clinics have been trained on CANs, and we are currently completing them at the time of intake and then every 6 months thereafter. As far as challenges, the typical, limited funding, not enough staffing, increased workload is something that we are trying to determine creative solutions for, but that's sort of the thing that we are all dealing with. It's been extremely difficult in our county to recruit TFC and ISFC homes. I don't think we've recruited any. CWS can chime in if I'm misinformed on that. Our youth with more severe mental health needs are being placed out of county. So there is a need in our county for more crisis services within the county. We believe that this would really support the continuum of care, as we all know that placing a child out of county, sometimes things get lost in the shuffle, or we forget to inform somebody, or it's just easy to not have a smooth transition or continuum of care. And then the other challenge that we have is that because our partnering agencies all use unique data systems and programs, we don't all have access to the same information, such as youth being placed out of county. So we're continually working on improving communication among our partnering agencies and ways to increase data sharing. I don't know what other counties are doing for confidentiality, if they have MOUs in place or what they're doing to address those issues, because we know that we have some kids who maybe are probation youth and not CWS. So the question that has been coming up for us lately is it okay for us to all sit at the table with these 3 agencies specifically and just freely talk about these youth? So those are the challenges. Now I'm going to turn it over to Deborah Hartman with Child Welfare Services, who will speak to CFT tracking and communication.
Thanks, Giselle. Very good job. Thank you for doing that. Before I start with CFTs, I'm just going to piggyback on a couple of things that were not in our presentation that I'm going to talk about a little bit about. So in regards to the AB 1299, actually, before this phone call, I kind of finished up the process along with one of our business specialists, so I'm going to pass it on. We're trying to make that as simple as possible because, as was stated by other counties, there's all these different initiatives coming along, and we're trying to figure out the prioritizing, which ones have the most that we need to deal with. We really don't have in Santa Barbara County as many kids placed out of county as we would for like level of care training. So trying to balance out all these new regulations and training staff. And we also have a lot of new staff too who are just learning the basics. So that's kind of where I think a lot of counties are, and we are with that. I just wanted to also piggyback on what Ventura County said about the mental health assessments and the KDA assessments. Our county has been, our Be Well, which is what we call our behavioral wellness agency here in Santa Barbara County, has been doing assessments on all of our kids for probably a year or two now that are in the county. So that's working out really well. And what we're finding out now too, like Ventura, we have different languages going on in terms of medical necessity, so to speak. And what we're coming on the same page at this time is that all child welfare service kids at least meet class. So they're entitled to some kind of service, whether it's short-term service, not service at the moment, or longer-term services. That's really important because, as you all know, child welfare services kids are all traumatized just by the mere fact they were exposed to trauma being placed in care, or even getting an abuse or neglect referral substantiated. Okay, now I'll talk about CFTs. So I just wanted, Santa Barbara County way back in 2001 was part of the Family to Family Initiative. So we developed PDMs really early on. So that was a good buy-in to a lot of our staff in terms of how important they can be. But since they weren't mandated, it was hit or miss whether or not workers are utilizing them. But with that, we are doing TDMs at the front end as well before we even have kids come into to be a case. So we're calling anything pre-going to court a TDM. So we have a lot of TDMs at our front end in the emergency response program, as well as also with VFMs. So our VFMs also have TDMs. And in fact, when kids or a case goes from our front end to a VFM, they have a TDM at that point in time. So along with that, we're also doing some process improvements with the CFT process. We're kind of doing it in stages. So we started off with the 60-day initial ones. So we're doing those probably 90% of the time now. Probably middle of last year, we were probably doing 10%. So it's a good flip around on that piece of it. And then our next phase was the ones that didn't have any CFTs, that had been in our care for quite a while, and are having a review in next couple of months. So we track down, we have a case staffing 2 months before we have status review. And at that case staffing, the facilitator asks whether or not a CFT has been scheduled, and we ensure that we have that in line with at least a status review hearing. So we're moving along with that and gathering data with that. So that's really good news. And we are also tying in a lot of the existing CFT meetings. We're finding out, like Ventura, kind of Pacific calls their meetings the CART meetings, so with the group homes. So they've been having these CFT meetings for years now. So we're tying in with those existing meetings and just making sure we're documenting them. The group homes have them, the FFAs have them, Be Well has been having them. So we're kind of tying that up, realizing that a lot of the CFTs that we're supposed to have aren't as many because we've been having them for years, just kind of tying them, coordinating them together. Let's see. Child welfare service staff, as we speak, are in facilitation training. So we had UC Davis come down all day today and all day tomorrow. It's the same training, but 2 different days, so we could have staff coverage to train on facilitation. So we have them here along with our probation. Some of our probation partners are attending that, as well as our contracted CFT facilitators. Let's see what else. What also is helping as well is our coordinator, our contractor coordinator, and our business specialists are individually attending unit meetings to help with specific questions unique to each of the unit's roles, because as we know, there's different points of time in regards to when we should hold a CFT and what that means, because we can't do everything in a CFT in 2 hours. And there's support to one another. And what's really fascinating and the workers are starting to see is that when we have a CFT, there's an accountability of all the members of the team. There's a shared participation. There are clear roles and expectations going on. They develop the support teams, the circles of support in the case early, to determine what specific services are needed, that they're timely and they're appropriate, and also, identifying what's working well, the worries and next steps in a CFT. And then the follow-up CFT, like 3 or 6 months later, it's built on the initial one, where we bring in the initial steps and kind of compare them, look at them, and kind of show the progress that a family or child has made in that amount of time. And also what's happening that's working well too is that now data tracking is becoming a little bit easier over time, although there's a lot of information we're trying to capture and we're realizing we can't capture it all. So the challenges with the CFTs is, and I think other counties have said that as well, is just the logistics and scheduling. When to schedule them based on workers' time, families' time, people coming in, getting all required parties to the CFT. Is it appropriate to have a child attend all of those, although it's mandated by regulations? Sometimes it's not appropriate. What does that look like? Getting the parents as substitute care providers in the same room sometimes, or the extended families, the parents, the step parents, and working on those engagements prior to getting the CFT. So working on all that simultaneously is a bit challenging. Also CFTs, as we know, up front is additional workload on staff. And I think I mentioned this as well too, is trying to incorporate all the different mandates into a CFT. level of care, the CANs, the presumptive transfers, the school stability decisions, all those kinds of things has created some challenges. And I think that's it about the CFTs. So I'm going to pass it back now to Giselle. The next one.
Okay, thanks, Deborah. So now the next slide is regarding continuous improvement. So right now, what's working well is that our behavioral wellness department is continuing to look at and improve templates in our electronic health record. And sort of to piggyback on what Deborah said, it's mainly to support the improvement of tracking, to be able to use data to really see where the needs are. We're also continuing to develop and improve services to identify levels of care, to ensure that the youth are receiving the appropriate level of mental health services that they need. We have access to data reports that will facilitate our ability to look at barriers and also what's working. Right now, the focus is on supporting timely access to services for KDA. And then, as I mentioned in the first slide, the data sharing among the agencies is something we would like to continue to improve. I know one of the other counties also talked about changes in management leading to a cultural shift, and I think that's something that we in Santa Barbara County can really relate to as well. Our county has also undergone significant changes, and the way that we're kind of looking at it right now is just kind of how it's presented an opportunity for us to take a look at and consider changes for our organizational structure. So we are really focusing on that right now as well. And then our final slide is regarding next steps. So for this portion, we decided to break down the next steps by the agency. So I'm going to start with the next steps for behavioral wellness, and then I'll turn it over to Julie, who will speak on the next steps for probation, and then back to Deborah regarding next steps for CWS. So in 2017, we trained all the supervisors as train the trainers on CFT facilitation, so they all have the capability now to train staff, which is something we would like to move forward with. We'd like to submit a triage grant application for age youth to build on level of care needs. So rolling that out and creating an FSP-TAE program is something that's in the works. And we'd also like to continue to train FSP RAP teams to increase capacity and complex capability for those youth with more severe needs. We're also working on developing a local form to document STRTP criteria to support the group homes who are trying to transition over to STRTPs. And I think just in general, we want to continue to be able to collaborate with the partnering agencies. And of course, there's always room for improved communication, but specifically we want to look at increased communication and collaboration regarding the youth placed out of county. And right now, what seems like we've been talking about at our meetings lately are to be able to iron out a process for presumptive transfer among our agencies. So Julie, if you want to go ahead regarding the next steps for probation.
And we do need to move just a little bit quickly through this to make sure that we get through all the counties.
Okay, and as far as probation goes, we're also participating in the CFT training that Deborah talked about. Thankfully, they let us join on board with that, and we're getting a lot of our staff trained in CFTs. And then we're also doing a lot to change our internal processes as far as our interagency placement committee meetings, CFTs, how we're documenting and tracking those meetings, and making the necessary changes to reflect the new STRTP placement requirements, and advising our courts and attorneys as well, and getting everyone on board. And over to Deborah for CWS.
Okie dokie. So, besides on the slides here, we're working on developing the MOU that was in the CCR template ACL. So we're meeting actually this Friday to develop that. We already have an MOU, but we want to beef it up and kind of update it. So that's the next step. We're looking at a process of reducing our number of days to approve relatives for RFA. We were also one of the first counties, and we're really looking at a lot of the qualitative homes and making sure those assessments are really beefed up, and looking at whether or not there's streamlining that we can do and still have the best homes qualitatively as possible. Working with a couple of our group homes here that were level 12s, so having some challenges in terms of meeting all the needs to become STRTP, And the challenge is that, you know, at the beginning, the state was kind of gave, as we were moving all along, it gave kind of different kind of confusing directions in terms of what was needed. So moving towards that as we grow, we all grow along with this. We're next steps are also continuing to engage with everybody a little bit stronger and develop the communication, whether it's amongst the agencies, whether it's amongst the resource families in terms of expectations. And then, of course, and then last thing, a wish list that we have for the last 5 or 10 years has been trying to somehow get a, either, you know, ISFC or TFC homes. So there we go. Any questions?
In the interest of time, we're going to have to go ahead and move on to Riverside County, but what we will do is post the questions on our website. Thank you so much, Santa Barbara County.
Good afternoon, everyone. This is Riverside County. My name is Chris Roselli with Children's Services. We're sharing the phone, so I'm going to introduce my compatriots as well. We also have Nisha Elliott with Behavioral Health, Monica Rose with Probation, Laura Smith with Behavioral Health, and Lily Gallegos with Behavioral Health. So we're going to present jointly. If we can go to the second slide. So when creating the presentation for the group, we have a model in a meeting that we've been using for a number of years, and we thought that this model really outlined the collaboration, not just in regards to CCR, but the collaboration that we've been trying to develop and continue to develop throughout the years. So we thought that this would be the best way to really kind of show, express to the group the collaboration between the agencies and our attempts to work together, share information, and just simply make sure that we're receiving the same information the same way. Next slide. So first up to talk about Continuum of Services is going to be Laura Smith from Behavioral Health.
Our Continuum of Services subcommittee has been focused primarily on the process from screening and initial screening and assessment all the way through the service delivery in all 3 of our systems, probation, child welfare, and behavioral health, and through the discharge or when a client is leaving our system. And initially, there was a focus on developing the mental health screening tool that we use for our county in terms of screening children and getting them referred from child welfare to behavioral health. And at this point, we are assessing all of the children that are referred over from behavioral health, and from there determining the subclass or class for KDA. And we're also using the data that we get from those assessments in our electronic health record to help share data with child welfare as far as determining our focus on the children. The subcommittee also has focused, each year they have a kind of a sub-focus, and a couple of years ago we were looking at underserved clients in our systems, and we focused on the 0 to 5 population and also adolescents. In a lot of the planning meetings, we're trying to determine how services could be expanded for those areas. And during this past year and coming up, we're looking at how AB 1299 is going to be implemented in our county, and then coming up how the CAN assessment will be implemented in our county. In terms of challenges, with behavioral health, we're looking at expanding some of our system of care services in order to meet the needs that were identified previously with the 0 to 5 population in the adolescents, and also with the AB 1299 preemptive transfer notifications that we're getting, looking at our county particularly has a number of youth that are placed from other counties, and trying to see how providing services for all of them will fit into our existing system. The subcommittee also looks at what our existing structure is and any kind of changes that need to be made in order to adapt to the gaps that are identified. That's pretty much what the Continuing Services Committee is focusing on at this point. And now,
okay. Our training subcommittee actually receives information from all the other subcommittees and decides how we are going to deliver this information, not only to every agency's employee, but also to our community partners. Some of this actually started in Pathways, and we have changed the Pathways information now to CCR to include CFTs, some presumptive transfer information to change from group home to STRTPs. And whenever we have training, we try to include employees from all agencies just to maintain that collaboration even in the training. Let's see. In the future, we are going to be incorporating CANs and level of care information for the staff and our community partners. Some challenges are that it's ever changing. Sometimes we'll have a complete presentation done and then we'll get some new information, so we'll have to make adjustments. But that's also been a struggle, just letting staff know that this may be practice today, but it may change in a couple of weeks. And I think that's about it for training. I'll hand it over to Chris.
Well, hello, everyone, again. So in regards to informing and communications, looking at time, I'm going to go over this information a little bit quickly. So with our informing and communication groups, basically what we want to do is make sure that we're constructing consistent messages that go out to all of the agencies, to our providers, to our community partners. With the number of ACLs that have come down regarding CCR and the past regarding Pathways, it was very important to us to make sure that, excuse me, it was very important for us to make sure that the same message was being presented, and as a result, again, the three agencies, probation, behavioral health, children's, and actually we also had education included with us. We just wanted to make sure that everyone's getting that same information that's coming down. So next up, data. So in regards to our data, and I believe maybe it was San Bernardino, I may be mistaken, but one of the other counties had shared that they were experiencing some of the same challenges that we have in the past and we continue to struggle with, which is making sure that between behavioral health, probation, and children's services, that we are using the same data for our same clients. What we found initially was that behavioral health was tracking their clients one way, we were tracking our clients one way, and probation was tracking their clients a third way, which obviously was not anywhere near the most efficient manner to be doing that. So really we've devised our data analysis group around addressing those issues and how can we come together to make sure that we're sharing likewise data. So in terms of KDA, we were able to construct it so that the customers we were looking at, both behavioral health and children's, were the same customers, and we're able to share information through databases with each other. It took a lot of work to get through confidentiality, and, going through legal and making sure that we in fact were, abiding by the legal rights of the customers, but that's something that we were able to work through. And again, with CCR, it seems like every time there's a new initiative, we need to revisit it again and look at the data. And again, how are we going to make sure we're pulling the same data not duplicating it and using it as a team effort instead of individually. So next up, Nisha Elliott from Behavioral Health is going to talk a little bit about CFTMs.
Good afternoon. I'm from Behavioral Health, and I think teaming and collaboration is something that we have always done well in Riverside County. So when we were at the point where we needed to develop the CFT subcommittee, we thought it was important for all agencies to be involved, since all agencies will be doing some sort of CFTs. So mental health will be doing CFTs for those individuals that don't have other agency connections, and probation is now doing CFT, as well as child welfare, of course, is doing CFT. So we developed our committee so that we all can be on the same page, so that we can provide the best meeting for families. So our committee is comprised of those 3 agencies, and there's a chair from each agency, so that we all can make sure points of all agencies are brought to the table. One of the things that we're focusing on is streamlining all the meetings. So we want to work for all the meetings to be named the same thing. So even though the imminent risk who don't have open cases don't really meet the criteria for CFTMs, that's what we call them. We call them imminent risk CFTMs for those who aren't in agencies, and probation is sometime at the table, as well as behavioral health is at the table. Then we have the pre-juris CFTMs. Those are the ones that happen before they go to court, and we want to make sure in those meetings that plans are developed so that when court happens, a plan from the CFTM has already occurred. And then lastly, we have the after the juris meeting, which we just simply call CFTMs, where of course we all come together to make those meetings happen. We have behavioral health clinicians that are co-located in the child welfare offices, and they have been for years prior to Pathways to Wellness and CCR. So that makes it a seamless process for the behavioral health to be able to participate in some of those CFTM meetings where those subclass or class kids have not been connected with mental health or behavioral health services. So that is a really supportive system. So we also reach out to our probation counterparts to make sure that we are involved in their conversations when children need mental health services. Their clinicians also support in that effort. Additionally, with the CFTMs, we want to be on one accord by having the same forms. So we work together to have the same forms so that families can either go through the system seamlessly if they have to just go to mental health or probation or child welfare. The system and the forms look the same so that the families can really understand what's going on and what information is on the form. And we try to make sure that we have parent partners and peers involved so that our forms won't be so confusing, that families can understand what's going on with their plans. Lastly, we talked about the one meeting model in which screening can be involved in that model, and some other meetings that families have to go to. We want to incorporate that in the CFTM so that families won't have to go to so many meetings, and so that their team can be one team all the time, and they're all focused on the same thing, getting these families connected, children back home or into foster placements, so that they can get the services they need, so that maybe one of the agencies can close their service delivery and they can rely on natural support. Some of our challenges are, of course, sharing information with which other agencies have talked about and other counties have talked about. Sharing information has been difficult. Scheduling has been difficult. Making sure that all the CFTMs are planned appropriately in a timely manner for the children have been difficult. But those are all things that we're focusing on reducing the challenge, and we focus on it in our CFTM subcommittee meetings, and we talk so that we can identify the problem and make a resolution to it and see if it works for the system. Thank you for your time.
Great, thank you so much. Okay, so we have about 21 minutes left. Do we have San Bernardino on the line?
So I'm sorry, this is Monica Rose from probation.
Oh.
We still have to do the interagency committee. Just very briefly, I'm sorry. Okay, so regarding the interagency committee on placement, I just wanted to touch base really quick. That chart that Chris initially showed, it's essentially a breakdown of all of the a breakdown of the committees that we form here in Riverside County. And so we have different committees such as CFT. We have an interagency committee on placement, which is what I'm going to be discussing. And so there's several committees that we form in order to set foundations for our process. And the IPC, which is the Interagency Committee on Placement, we essentially come together to talk about everything that relates to placement.
So we are talking about our RFAs, we talk about our STRTPs, and we are coming together in order to implement the process. We've created forms, we've created a process for all of our agencies, and we already had an established process prior to CCR. And so now what we're doing is we're just essentially refining the process that we had. And like for the IPC, when we get together and we do screenings, we have our forms that are now incorporated the STRTP criteria. And we come together in order to discuss what's working, what's not, how to refine the process, how to continue implementation. And so one of our, for example, one of the processes that we're working right now is part of the dispute resolution regarding the ACL for the criteria, the eligibility regarding the STRTP. And through this committee, once we come up with the process, then we'll report out to our executive team. And that is pretty much what we're doing here in Riverside, and that's how we're getting our system in process. And so I'm trying to think if there's anything else. So I think just that's pretty much it as far as the IPC, the Interagency Committee on Placement. So thank you very much, and that's it for us. Thank you.
Thank you, Riverside. Okay, San Bernardino.
Hi, San Bernardino is on the line. This is Nikki Hackett from Children and Family Services. I'll be presenting with Tim Haugen from Department of Behavioral Health and Jeannie Glasgow, also from Children and Family Services. And present with me in the room is also Probation and our Transitional Assistance Department. Regarding STRTPs, our group home exception process is running pretty well. We are using a SharePoint site so that all 3 departments can review the program statements and other documents at once, and that's working very well for us. It's also working well for us to hold face-to-face meetings with applicants who really need some serious revisions. Our local group homes are understanding their conversion requirements better than they did last year. We're still very concerned about a few homes, but actually all of our local homes say that they plan to convert. We recently made a presentation to each of our county supervisors, the Probation, Department of Behavioral Health, and CFS regarding CCR and STRTPs, and that was a really good use of time. It helped them to understand and support us, and it gave us the opportunity to recommend streamlining our protocol for recommending new STRTPs. The new protocol will include more collaboration and communication from the applicants to the community up front. We're still experiencing rejections and 7-day notices from STRTPs, and we are reporting those to CDSS monthly. We're beginning a step-down plan for our young children and our children in lower-level RCLs, and that's with our placement coordinators attached to our centralized placement unit, working with our regional social workers and supervisors to make sure that they're using all the CCR strategies available to help step these kids down. Moving on to FFA. The impact of CCR on coordinating and transitioning mental health services isn't clear to us yet. We do have contracts with about 12 FFAs and where DBH is working them to make sure that they're mental health certified, but it's really not clear to us whether this is having an impact on the kids yet or not. We also are contracting with 20 FFAs to assist with our county RFA permanency assessments. We've referred out almost 200 assessments. And what we're finding is it requires a significant amount of our staff to help coordinate that effort, get the consents, and make sure that the referrals are moving along properly and coming back. Our ISFC requirements are not entirely clear to us all yet, but so we look forward to that. We do know that one local FFA is planning on trying to convert all their medically fragile homes to ISFC homes, so we're encouraged by that. Regarding the LOC tool, we're about halfway through training our staff. We appreciate the implementation delay to March 2nd, but having a 2-phase process has been a little confusing and complicating understanding. We gave feedback on the SCI process to CDSS last week. We support having a 3-tier statewide system. That seems like it'll work well for us. We had some other suggestions that we made, though. And Tim's going to talk a little bit about therapeutic foster care.
Hi, so we've really looked at the manual recently that came out, and from my perspective for DBH, this is enough for us to then move forward. We have some of the technical stuff in place. We have, as Nikki said, we have contracted relationships with about 12 FFAs, and so they're already Medi-Cal certified. They've been providing EPSCT services. So this is just going to be an expansion of that. Where our plan is to really explore that with them, maybe identify a small group to move forward on getting therapeutic foster care on the way. Our hope is to have something up and running in about 6, 7, maybe 8 months.
And then Jeannie's going to talk a little bit about our mental health screening process.
So we developed a process that we call RSET, so that children entering care are all screened and assessed in a timely manner. We changed the way we use our service coordinators, who now document initial screenings. They make the assessment appointment. They send appointment reminders to caregivers and change appointments as necessary, which has dramatically increased our completed assessments. AB 1299, we started sending out presumptive transfers and waivers. We are struggling a little bit with social workers not understanding how AB 1299 works, and also how different counties have different services, so it gets confusing for the workers. We have the same service coordinators are the ones that are notifying the other counties that the children are placed in. Some other counties are still asking for foster youth to be served under SB 785. And we also need clarity on who has the authority in each county to consent for treatment, because it changes county to county. In regards to CANS, we are part of the first cohort, which is supposed to go live in July. CFS is planning on starting implementation meetings in March, and DBH is doing CANS and brings it to our CFTs currently.
Then regarding CFTs, it's been helpful to utilize clerical support to set the due dates for the social workers and send reminders to them. We've had a struggle to get CFTs documented, but documenting it in the Associated Services page is improving those efforts. It seems from the ACL that it's asking us now to document CFTs in 2 areas of CMS, and we're not exactly clear on why that is. Our social workers are all trained as facilitators, and they're receiving coaching. We also developed a facilitator fidelity tool, but its use is not mandatory. Moving on to RFA, I'm just going to talk a little about this because we could talk about RFA for an hour if we needed to. But the best part of RFA is that our training of caregivers is going very well, and it's very appreciated by them. And that was after a really rocky start. But once our social workers realized that they had to address the concerns and the anger at the relatives of being there right in the beginning, and they all developed a different way of doing that. But once that was done, then the people were able to learn, and they've really enjoyed it. Our social workers and our contracted providers are both struggling to meet the time frames like the rest of the state. The no payment until approval is a big problem for our non-related extended family members with ER placements because they don't qualify for CalWORKs, and we don't provide any other payment. We're using business process mapping and daily supervisor touch base meetings to try and improve our process and reduce our time to approval. Regarding MOUs, we already had in place an administrative joint management MOU for CFS, DBH, and probation ever since KDA implementation, and that's transferred over for most of CCR. We did develop an MOU with probation for the RFA process, and then we already had several data sharing and program MOUs in place with DBH, so we didn't need another specific CCR MOU. Regarding CQI, that's been a focus for us. CFS is receiving consultation from Casey Family Programs, and we get coaching from PICTA. We use a 9-step logic model, data-driven decision-making plans to track our progress and to identify the areas where we want to do work. 2 hours of each of our combined managers meetings are devoted to CQI and developing our skills in this area and pushing the plans forward. Our operational regions are working on fidelity to the SDM risk and safety tool. I think that the other counties are aware that we came to SDM later than most of the other counties. And then our specialized regions are working on program-specific plans, including improving placement matching, improving RFA timeliness, and several others. Looking at our successes, lessons learned, and our challenges. Our successes are definitely the RSAT process that Jeannie was talking about, which has resulted in many more assessments for kids and a huge reduction in no-shows to assessment appointments. Our RFA training that I already talked about. And then also one of the things we did for RFA was develop the resource family specialist position, which is the use of former caregivers to support our resources family. That's been a resounding success. I didn't mention the collaboration that we share because we're in the enviable spot in San Bernardino County of having had that in place for a very long time, and we're very fortunate to have that. And also Imperial County talked about the collaboration with other counties, and we're very appreciative of that too, especially to Riverside County. We've been very much in touch with each other. It's been very helpful to us. Lessons learned is that contracts require a lot of coordination and a lot of effort. DBH has devoted hours and hours to Medi-Cal certification training. It's taken us a lot of effort to coordinate the RFA contract with the FFAs, and that nothing is more important or harder than the degree of communication and follow-through that's required by CCR at every single level. The challenges that we have are securing placements, home-based placements for our highest needs youth, finding families that are willing and able to provide a home for kids like that. ACLs coming late and having surprises in them is a little difficult as well. And then, of course, like everyone says, meeting RFA timelines and not having foster care payment. So I think that's our presentation. Thank you.
Thank you, San Bernardino. Okay, so we've got San Diego. We are going to run over a little bit late, so for those who can stay on, that's great. We'll go ahead, probably go to 2:45. If you have to jump off, again, we will offer a recorded version in our website. So let's, San Diego, if you can wrap up the county presentations, that would be great. Thank you so much.
Sure, thanks. So this is Kim Giardina, Deputy Director with Child Welfare Services, and I have a couple of partners on the phone with us. From Child Welfare, I have Stephen Wells and Charisma de los Reyes. From Behavioral Health Services, I have Amanda Lance-Sexton, and from Probation, we have Frank Andrade. If you can go to the next slide. So just some quick highlights for us. We have been working really hard on converting our emergency shelter over to the 10-day shelter. Right now, we're getting about 95% of our youth to leave within the 10 days, and our average length of stay is about 7 days. So we have been really successful in doing that. We currently have about 125 youth in group homes. That's about a 17% decrease for us since we started CCR. Which we had already previously had a pretty significant reduction in the number of kids in group homes. We've just finished procuring our CFT facilitation contracts. I think we're one of the few counties who's actually contracting out the facilitation of CFTs. This first year of implementation has been a bit of a struggle to get our staff to do those CFTs, so we decided to contract that out. So the contract will start July 1. We've also procured all of our FFA contracts. We've contracted with our FFAs for several years now, and we had to do new procurements for to meet the requirements of CCR. So that has now been finished. We're ready to implement the level of care assessments. We were lucky enough to have 2 of our staff in our county be very involved in helping to develop the level of care assessment, so they were able to make sure that we were prepared and ready to go to get this implemented. We've been implementing the new IPC process for all of our kids in group homes. So we don't have any homes that have officially converted to STRTPs yet in our county, but we've been practicing the same processes that we'll need once we do have those STRTPs so that we're ready to go. And we're in the process of reviewing all of those program statements. So I'm going to turn it over now to Charisma and the rest of the team to talk about some specific components.
Actually, Kim, I'll go ahead and let Stephen go first. Good afternoon, everybody. My name is Stephen Wells, and I facilitate our interagency placement committee process. And to follow up with a few things that Kim mentioned, we're really proud of our process because our team really tries to meet our CCR goals from both sides of the picture to try to reduce our utilization of group home care. And the one side is for kids that are at risk, we try really hard to focus a lot on using the IPC process to do kind of a case consultation discussion about what's available, what are the resources, what are the treatments, how can we support a youth through permanency activities or treatment, or using our safety organized practice to try to prevent, if at all possible, youth to go to group homes. And then on the other side, we really try hard to have robust discussions whenever a youth comes back for a revisit or a recertification to make sure that we're really always keeping our eye on the ball for family finding or family engagement. So we have begun really having the discussion about group homes being a short-term treatment intervention and moving away from placement type of language, exploring family networks, and utilizing our Pathways to Wellbeing staff or our KDA staff to really maintain knowledge about mental health resources, to lean very heavily on our behavioral health partners, who is a part of our team, and utilizing their expertise and knowledge about resources in the county to make sure that we're really making the best possible decisions and referring youth to the right services at the right time. We have a really strong team that includes our staff psychologists, public health, our Polinsky Children's Center staff, San Pasquale Academy, probation, and our dedicated permanency staff to make sure that we have a multifaceted approach to the discussions. And with each one of those meetings, it comes out with a really strong set of recommendations to go forward in the short term, but then also always keeping an eye on the horizon 6 months from date of placement to make sure that we're considering family environment from day one of placement. Some of the challenges that we have is, and we're very proud of our outcomes on the 10-day timeline for our shelter, but in situations where we need a very quick IPC, we hold our IPC once a week, and sometimes we have to act a little bit more, it needs to be a little bit more agile than that, so sometimes we have to do sort of an ad hoc or emergency IPC. And then finally, as we've adjusted our process and our criteria, our partners, FFA partners and group home partners are not as up to date on our new processes. So we just need to go around and do some partnering and some training with our FFAs and group homes to make sure that they understand our updated IPC processes. Those processes have caused concern in our provider community about how those decisions are made, and certainly with our group home providers is a concern as far as making sure that we are sending the youth who need group home care to group home care as we're intensifying our efforts to place kids in family settings. So with that, I'll pass it on to my next partner.
And so this is Charisma de los Reyes, and I'll be rounding out the last section for child welfare before I pass it on to our partners at VHS. So the topics I'll be covering are the CFTs, ISFC, and LOC, and just to further add to the introductory remarks that Kim, our Deputy Director, brought up. So for CFTs, what's been really working well is that we've been able to incorporate or include over 80% of youth in our CFT meetings, which is something we are quite proud of. And our satisfaction surveys are showing that families and workers are very much feeling that these meetings honor their voice and include them in their own plans, which is the, very much so the intent of the CFT. Some challenges, that we're facing or, that we're fielding and trying to really, put some folks at ease, and we won't know until everything's kind of put in place with the contract and things like that. But naturally, workers and supervisors are feeling worried about having enough time to attend, all the meetings that are required at all the different timelines of, whatever the case need may be at that time. And then, of course, on the capacity part for our contractors, who will be our facilitators, will they have the capacity to serve at that? And we're pretty agile here, and we're pretty good at keeping track of trends and things. So I'm confident that we'll be able to amend the contract if that is in fact what is needed. And then finally, for the CFT section, working on the coordination of efforts for all 3 departments through the contractor and our partnership to streamline meeting requirements and have families and workers attend one meeting to get everything done. So it really is echoing what everyone has mentioned about the streamlined process and just being very cognizant of the additional workload pieces. But again, the intent, is to make sure we're doing work collectively. For our ISFC, we've established a multidisciplinary work group that includes all of our partners as well as all levels of workers, because that really is what we're finding as a lesson learned to be the best way to take on these different moving parts of PCR. I think that was an echo. Okay, so one of the concerns naturally that has come up, immediately with our work group is having a pool large enough of approved ISFC resource families, and then of course training them. And so we know that our mandate is to really develop, a curriculum on what an ISFC family should be trained in. And so one of the things for implementation or for planning is that we're devising a targeted recruitment plan for ISFC homes based on, certain data trends and of course just general interest from families maybe who've worked with us for a long time and may be ready for, a different caregiving model, or even new families who may come in. And then also, what does that look like for relatives and nephrons? Like, would it even be feasible? Considering like emergency placement and those other factors. We're consulting with our local foster parent training program and FFAs, again, to develop what really should be in this curriculum. And then in looking at how are we gonna offer this kind of ongoing, easily accessible 40 hours of training as, resource parents come through, that I think maybe the best plan for us is in looking at amending our existing foster parent training contracts. Because again, that's going to be a huge, huge lift, and we need to make sure that those trainings are available and not a barrier, but truly a support. And then so lastly, for my section for the LOC, what worked really well, again, was this, the work group of staff from all levels and all affected departments that really came together to look at the process and craft policies and practices that would work best for workers as well as caregivers. All our workers are trained. The policy will be published next week and we'll be ready to go for the March 1st start date. Some challenges definitely just have been, being agile enough and responsive to when new things have come down, new instructions have come down from the state. But, again, it's just been, good practice in our ability to respond. There still is some unknowns around how to apply the LOC to AAP permanency placement, and I know that the state will be forthcoming with that information. And so some future planning and implementation, the steering committee or the work group will continue to meet quarterly to make changes as needed, because it definitely is a living, breathing process. And that we will continue to also meet monthly with all of our LOC workers, so these are designated workers, to assess, what's working well, what are the concerns and worries, and what may need to be changed. And these meetings with our staff will include trainings, updates, and inter-rater reliability activities to ensure consistency amongst all of our regions. And so I'll go ahead and toss it over to Amanda with BHS.
Thanks, Charisma. This is Amanda Lance-Sexton with Behavioral Health Services. So I'm going to do a brief overview of what's working well. So for us, one of the biggest components that Behavioral Health Services has rolled out for our contracted provider network as of January 1st this year is an update to our previous Pathways to Wellbeing one-day training. We've now shifted over to a core practice model training, and it includes the integrated pieces of the Continuum of Care Reform in order to ensure that all of our contracted mental health providers are informed of the latest legislation, including CCR, CFT meetings, et cetera. So within that training, we've been able to educate the providers about their roles in these shifting CFT meetings, and also assisted them along the way of co-facilitating some of those meetings because of the pathways to well-being timelines that we're looking at with the mental health components of the child and family team meetings. Another important piece would be the upcoming transition to STRTPs. So BHS is regularly attending bi-monthly FFA and STRTP meetings with Child Welfare Services in order to provide regular mental health requirement updates for both PFC and STRTP. And we're reviewing the program statements with our partners and meeting with potential STRTP programs regarding the mental health contracting components, which is a huge undertaking for many of these group homes who have not previously been held to the Medi-Cal standards. So we've also moved forward with shifting our fiscal structure for STRTP contracts moving forward in order to sort of align with billing units, units of service, and to ensure that the youth that are in the group homes are really getting the highest level of intensity of services when they're placed there. And another important piece is the most recent development is a CCR administrative team that we've been able to write into our ops planning. And so we will have a designated program manager who will be working closely with our Pathways to Wellbeing administrative team in order to assist our STRTP programs that are transitioning to adhere to the new model. So they will be our experts at the state protocol and helping these programs that are shifting over and beginning contracts with us as they go through the licensure process and the mental health program approval process. We also have BHS representatives regularly attending the IPC meetings, and I know Stephen spoke to the IPC placement committee structure. And so we have the mental health voice both in the child welfare meetings and the probation meetings. And we're also moving forward with integrating working on our TFC model for contracting in order to provide services for youth who reside in our foster family agencies. Some of the challenges that we're currently facing is, of course, the additional staffing that other counties have mentioned as well, particularly for the oversight of mental health program approval process. The timelines are different for the Medi-Cal processes, so that's going to require some shifts in our infrastructure and administration in order to adhere to the new timelines, which will be different from our other Medi-Cal contracts. BHS is also waiting on the state for a revised interim mental health program approval for STRTP protocol. Many of our potential STRTP programs have asked for updates around that, and we're sort of on hold in terms of knowing exactly what the mental health program approval is going to look like. We're also not only a challenge, but a little bit of a surprise. We're looking at a potential increase in group home contracts, STRTP contracts under Continuum of Care Reform. I think when we went into this, we were anticipating that the group home provider network would shrink. But what we're seeing through our program statement approval process is really that there's a potential for the group home, the number of STRTP/group homes to actually grow through this process. There are new group homes coming into play that weren't involved prior to CCR and the transition to STRTP. Plans for continued implementation, so continued joint meetings with our system partners, and of course the increased integration of probation into the collaboration with CCR. Development of an administrative CCR team to work with our STRTP programs through the shift to the new model. The implementation of TFC services, we're looking at that contracting to occur likely within the year. The collaborative implementation of a CFT facilitation contract with Child Welfare Services and probation, and then working also collaboratively in our implementation of the CANS outcome measures. We are doing that undertaking and plan on having that process in place in BHS by July 1st, and we've been working with Child Welfare Services as their integration is occurring on a slightly different timeline, but we're hoping that we'll be able to access the same resources through that process. And with that, I'm going to hand it over to our system partner, Frank Andrade with probation. Hello.
All right, so it doesn't look like Frank is on, and we do need to wrap up. So what I would like to go ahead and do right now is I was going to do some generalized takeaways, but I think I want to, just because we're running over, I think I'm going to kick it over to the state folks. So Val, if you could just put up the PICTA slide for right now, that would be great. And then if we could have Department of Healthcare Services come on board and spend about 5 to 7 minutes. I know it's a really brief period of time, but I really also want to get to CDSS. So if you could spend a few minutes just talking about TFC, that would be really helpful.
Thank you. This is Teresa Castillo from DHCS. Can you hear me okay?
Yes, we can hear you.
Perfect. Well, first of all, I just want to thank you and the counties for inviting us to join today's webinar. So really appreciate being able to hear what counties are doing, not only in regards to CR, but also in regards to TFC. And as background for those of you who don't know me, although I was able to recognize many of you from behavioral health or mental health plans, I'm happy to hear you report out today. But for those of you who don't know me, again, I am Teresa Castillo from DHCS, from Mental Health Services Division, and I oversee at the state level implementation of TFC services. I was happy to hear the updates that the counties gave today in terms of TFC. I was trying to see if I could pick out specific questions. I understand that there are specific questions that counties have, and I know that we are out of time, but I would just invite you and also let you know that you can send us specific questions that you may have around TFC to our KDA inbox. So that would be kda@dhcs.ca.gov. So that is a resource that I wanted to make sure that you continue to use. Any questions that you may have, requests for TA, please feel free to send those through the KDA inbox. And then to circle back, as a quick update on TFC, as some of you mentioned, and hopefully all of you know, that we did release the Medi-Cal manual for intensive care coordination, intensive home-based services, and therapeutic foster care. I think it was early this year, so it's been out for a few weeks now. We also released the TFC resource toolkit, which does provide a specific learning objectives that tie to the specific training requirements that TFC will need to meet, that TFC parents will need to meet. So wanted to make sure that I at least mentioned today that those two resources are out there. We know that some counties were waiting to have those documents to be able to move forward. So just again wanted to make sure that I mentioned that today. We're hoping that the information included around TFC in both of those documents will help you continue to move forward in how you assess where you are with TFC and how you determine next steps and plan out to implement TFC services. We've heard from various counties that counties are looking at various approaches for how to pursue with TFC. One of the key items, and I think some of you did talk about this today, is that many counties are looking at ISFC as being the kind of the launching point for TFC, and looking at FFAs that already are either Medi-Cal providers or FFAs that have ISFC that could expand ISFC and then look into providing ITFC. And other counties are considering different strategies. Some counties actually don't have FFAs, so are looking at a different structure for how to move forward.
So we've heard anecdotal information from counties pertaining to different strategies on how to address implementation of TFC. And to that effect, we are looking at developing a survey so that we can get information from all counties, so that, again, we also are able to identify where additional TA might be needed. I think that's the key of the update that I wanted to provide. Again, mentioning the resources and mentioning that if you have a specific questions, please don't hesitate to reach out to us. We would be happy to have a separate discussion with you if needed. So just wanted to make sure that I said that. So with that, I know we're short on time. So if anybody has any questions, any comments, I would be happy to address those now.
And just as a friendly reminder, feel free to type in your questions in the chat, and then any questions we don't get to today, they will be posted on our website. But if you have any questions, please feel free to use your chat box now.
Okay, so why don't we, if there's some additional questions that come on, we can either answer them if we've got a few more minutes, or we can answer them on the website. But why don't we turn it over to CDSS? I think, Daisy, are you still on the line?
Yes, I am. Thank you. Hello, everyone that's still with us here. So let's see. There's one question that I received, but just to also share with you all that the ACL that's going to describe the intensive services foster care ISFC program, we are hoping will be issued by the end of next week. That is the hope for that, so we're that close. So it will answer many of your questions regarding the ISFC program. And so specific, the question that was shared with us is that it asked youth who previously qualified as needing ISFC placement may not qualify under the LLC rating because the LLC is based on domains in which the scoring determinations for the payment and placement. So I wanted to first clarify a little bit that there were no previous ISFC youth. There was the ITFC, and in our ACL 1711, we indicated that any of those existing youth, children that were in the ITFC program, they were automatically converted to ISFC, specifically the same rate for the ISFC, effective December 1. So I just want to make that clarification. And then going forward with regard to ISFC and the level of care protocol tool and the rate determination, the rate for ISFC is built into the tool, specifically any of the needs that we would anticipate a youth who would have care and need supervision that would be equal to the ISFC rate, they are built into the tool. So in other words, if those needs are being identified, where you would find them and then ultimately score that youth on the LLC protocol matrix should equate to the rate. So having said that, to respond to the second part of the question, we do not anticipate that your findings in using the tool would not equate to those needs being identified. And so just to check myself if that was clear to anyone, let me just stop and ask, is there clarification needed to that response? Or did that make sense? Okay, so the second part, just to be clear and to go over the question, I'm not sure that everyone has it since I'm new to this format. It asks that if the above occurs for children who need intensive services, but the LLC scoring does not match their need, what is the plan to make sure that the youth are still receiving the services they need? So again, with regard to existing youth, who were in ITFC, those same youth and their needs, and also the resource parents now, i.e. foster parents who would have been caring for them, they would automatically map over to the ISFC, both in the rate and the expectations, generally speaking, for ISFC. And that is identified in the existing ACL 1711 with regard to the rate and how ITFC was being treated, as well as in the ISFC letter restates what's in 1711, that the ITFC rate and expectation does map over for ISFC. Did I lose everyone, or?
No, we're here. If anybody,
okay.
Yeah, so if anybody has any questions, they can go ahead and continue to type it. There was a question in the chat for actually Teresa at DHCS. Is there a potential release date for the updated interim mental health program approval protocol?
So this is Teresa from DHCS. That doesn't fall within my area. However, what I've heard from the team that is working on that is that they are very close on being able to release it, but I don't have a specific date yet.
So the only other thing I'd like to offer, just in the event that some are not aware, that we do have a dedicated mailbox for the level of care questions, and that mailbox is LOC, level of care LOC, at dss.ca.gov. And then also Loch Nguyen is working with counties as well to retrieve questions specifically from the county and to also shepherd those between the counties and our branch as well. That's all I have.
Great, thank you so much. And Audrey actually put that, she put both that email address as well as the KDA email address in the chat for those of you who didn't get that on the call. You can access it there. With that, I actually think we're going to go ahead and wrap up this webinar. I'd like to just really just say thank you to all of the counties. You know, I emailed you and said, hey, why don't we do a webinar? And you guys provided me with some presentation material, and you all did it, and it really goes to show really just, you know, how much everybody is sort of willing to kind of collaborate, you know, across counties and sort of share what's worked and what the challenges are so that we can kind of move forward on our implementation. I definitely saw some, again, I continue to be really impressed by, you know, all the work that our southern counties have been doing. You could really see the efforts in terms of, you know, using CQI systems, you know, existing systems, beefing up the current systems, developing CQI systems that work kind of across programs, and you can see kind of how that is helping kind of sort of shepherd the work and helping with any potential course corrections. And then I also really wanted to note that I definitely saw, you know, concerted efforts by everybody around using kind of that upfront teaming process as a significant reduction strategy in terms of young people in congregate care. So it's not just about getting our young people out of congregate care, it's about how do we avoid those placements down the road. So again, really impressed. I'd like to just say thanks again for all of the counties and their presenters, as well as our state representatives, and then of course to my colleagues Val and Audrey who are helping me behind the scenes. So thank you all very much. I hope you have a good rest of your afternoon.